I am Dr. Shrikant Bhoyar, diabetic food surgeon, practicing at Dr. Bhoyar's Diabetes and Diabetic Food Clinic, Mumbai. We have two branches. One is in Ashokwan, Borivali East, and this is the Advanced Diabetic Food Clinic, which is managed by me, diabetic food surgeon, and Dr. Medha Bhoyar, who is a diabetologist who manages the medical problem. So what is diabetes and diabetic food? Diabetes is a major problem all over the world, and especially in India also. Near about 100 million people are suffering from diabetes, out of which 25% patient will have diabetic foot ulcer. And foot ulcer is the pivotal event which can lead to the amputation of the foot and leg. So prevention of ulcer, and if ulcer is there, healing of ulcer is very much important in the management of the diabetic foot ulcer treatment. Now if you come to the pathogenesis of the diabetic foot ulcer, there is neuropathy, vasculopathy, infection, joint mobility restriction, and immunity. That there is a decreased immunity into the diabetic patient. If we come to the neuropathy, there is a sensory neuropathy, motor neuropathy, and autonomic neuropathy. If we come to the sensory neuropathy, the touch, pain, temperature comes from the sensory nerves. This is lost in the diabetic patients. That's why any small injury go unnoticed and becomes a big problem. And most of the time when the patient they come with a very big unsalvageable foot infection, which lead to the amputation. So if we tell the patient his foot has become insensitive and how to take care of the foot, most of the problems can be solved there and there only. Because in India, 85% of the foot ulcer take place in the neuropathic foot. So if we tell the patient how to take care of their foot, 85% amputations can be prevented with this cause only. Now coming to the motor neuropathy. Motor nerves supplies to the muscles. Muscles attached to the bones. There are 28 bone, 48 joints, multiple ligaments into the foot. There are intrinsic muscles also, which are origin insertion into the foot, and extrinsic muscles, insertion is there into the foot and origin into the leg. So the infection can spread along the tendons to the leg, and when there is infection, this can lead to the amputation. Because of motor neuropathy, the biomechanics of the foot changes. Some muscles become more atrophic, some muscles become less atrophic, where there can be foot imbalance, and where there is a pressure comes, the chance of ulcer developing is much higher. As well as there is a restricted joint mobility. Restricted joint mobility leads to the ulcer formation at the pressure point where there is a bony prominence is there. So which can be again corrected by the internal offloading surgery, which is our main basic points. Then comes the autonomic neuropathy. In autonomic neuropathy, the sweat secretion or the oil secretion on the skin, which keep the skin moist, is decreased, because of which there can form the fissures on the foot, and these fissures can get infected and lead to the amputation. Simple application of moisturizer can prevent these problems. Then come to the vasculopathy. There can be macroangiopathy and microangiopathy. Macroangiopathy means there can be atherosclerotic disease just like any other part in the body as such, like heart and peripheral vessels. Microangiopathy, which is unique to the diabetic patients. There is a endothelial inside the basement membranes are swollen, and there is a calcification in the medial wall of the arteries, which can lead to the stiffness of the arteries and leading to the slow blood flow into the leg. So when there is any ulcer is there or wound is there on the leg, enough blood supply doesn't go over there, and because of neuropathy again, patient will not give very important to the food. In the India, we generally have a dictum that more the pain, more is the problem. No pain means no problem, and that is the problem. In diabetic patient, no pain is the problem, and that's why these ulcers can lead to the infection and then amputations. So I will repeat, if we tell the patient, in a neuropathic patient, how to take care of their foot, most of the problems can be solved there and there only. Again, I will like to stress that just like heart, we can do angioplasty and bypass into the leg also. This is also not known to the many patient, and then can again lead to the problems. So we can improve the blood supply into the leg and foot and heal the ulcers. Then there is a restricted joint mobility, because of which the joint becomes stiff and then the pressure comes. So this can easily come out with the internal offloading surgeries. I have been doing a lot of internal offloading surgeries which not only prevent ulcer but heal the ulcer completely. For example, if we take the interphalangeal joint ulcer, IP joint ulcer we call it as a, if the patient come early and have a good blood supply, we can do the Keller's orthoplasty and heal the ulcer completely. I have up till now done the near about 65 cases of the IP joint ulcers, and not a single patient has come back with a recurrence of the ulcers. And that proves that Keller's orthoplasty is the treatment for the interphalangeal joint ulcers. Likewise, there is the tip of the toe ulcers. This again can lead to the infection of the bone, which can again lead to the amputations. So simple flexor tenotomy can be done to making the toes straight, and the problem can be solved there and there only. Just like that, then again MTP joint ulcers again can be treated with the floating osteotomy, or there are first MTP joint ulcers can be treated with a peroneus longus to peroneus brevis transfer, Jones steno suspension, and if there is an ankle is stiff, we can go for the gastrosolius recession surgery. There are many more surgeries. Even for the heel also there are surgeries. Even for the tendon, if it is ruptured, we can use the other tendons like flexor hallucis longus tendon to replace the main tendo Achilles and give the foot to the patient, who can go for a long time. Then I will say that again the patient who have diabetes have a reduced immunity that can lead to the infection. Infection again is the main problem which can be taken care with the surgery or other devices. We are going to introduce the cold plasma therapy, and we are hopeful that there are resistant bacteria into the diabetic foot ulcers. With the cold plasma therapy, we can reduce the load of the bacteria, fungi by 90% into the ulcer. This is a developing instrument which has been trying to develop by the BARC, ISRO, as well as NASA also. Some new improvement also coming. Topical oxygen therapies, antibiotics, new antibiotics are coming, which help to cover up the infection. And basically, surgically, we can remove the infection, again do the debridement. Then we can do the vac machine dressings also, which is also very helpful, and do the skin grafting and cover the ulcer. Remember that keeping the wound open is not a solution. Is not, because that will be again nidus for the infection. Closing the wound in a diabetic patient is a challenge, but it should be done to complete the treatment, and that is very much important. Now coming to the prevention part. Generally, when the diabetic patient comes to us, we tell them not to walk barefoot. Walk with a diabetic footwears all the time. Do not sit cross-leg, because when they sit cross-leg and there is neuropathy, they can develop ulcer on the lateral malleolus and again becomes difficult for the heel. Always walk with the diabetic footwears. Then do not apply hot or cold fomentations. For example, suppose in India we take the pilgrimage, go to the temples and these things in the summer season, and there is a hot 48 degree temperature is there, and we have you can say habit of removing the footwears outside and walk from the gate to the main temple. There is a hot sun and there are tiles which have become very hot. The diabetic patient do not feel this hot temperature and they walk easily, and when they come back they develop the ulcers on their foot. So to prevent that, they should use the footwears or the temple socks which we have developed. If the patient have surgery on the diabetic foot ulcer, he should not walk on the ulcerated foot. And then there are again offloading footwears also, which we provide to the patient. Anterior waist shoes if there is a ulcer of the anterior part, posterior waist shoes or middle waist shoes. There are many more footwears are also there which can be used. Basically, I will like to tell the patients of diabetes that take care of your foot as you take care of your face. How many times you see your face in the mirror, same time you must see your foot also. Keep one mirror for the face, another mirror for the foot, because that is very important. These patients are elderly patients, cannot bend their knees, so nobody is there to look after. So just keeping the mirror at the foot level can help them to see the foot and inspect the foot if there is a fungus is there, because 26% of the patient have the fungal infections there. If there is a redness there, if there is ulceration is there, there is a lot of things are there which can they easily catch up and run to the doctor and get treated and prevent the further complications, and that is very important. Other part like diabetes management is very important. Strict diet control, exercise, physical activity, because this is a lifestyle disease. Diabetes is a lifestyle disease, so this is also should come along with that to prevent the further complications in the diabetic patient. Don't worry about the diabetes. We have patients near about 25 years, 30 years, and we are managing them with the medicines, insulins or this thing without any complications on the foot. We have seen that patient is not worried about heart attack, but definitely he is worried about his foot amputation. So at any chance he want to prevent the amputation. So to prevent the amputation, he must take care of his foot. That is the main thing I will like to say. Thank you so much.